السلام عليكم ورحمة الله وبركاته. Welcome back all doctors and our colleagues. أتمنى تكونوا خذيتوا وقت وريفرش. أنا اسمي عبد الله عطية، R3 in Family Medicine Board. And it's my pleasure to introduce Dr. Yasmeen Yahya, our Family Medicine consultant with over 15 years of experience in teaching residents. She is a trainer in Shab Center and examiner in Kuwait Family Medicine Board. She holds the MRCGB qualification as well as diploma in diabetes care and education from the University of Dundee, and also she got the diploma in healthcare and management, healthcare management and quality from Gast University. She will share her experience with us today by talking about dyslipidemia guideline and how to manage it. The one of very important subject. دكتورة ياسمين، مساء الخير، ومايك is for you.
Thank you so much, Dr. Abdullah, for your introduction. I'll just share my slides. Okay, Bismillah ar-Rahman ar-Rahim. So, as Dr. Abdullah mentioned, I'll be talking today about a very important topic that we encounter on a daily basis. I'm sure that all of you read on a daily basis the lipid test results for the patients, and you need to understand how to interpret these results and how to manage your patients accordingly. I'll just give you a few examples as an introduction to my lecture from cases from my practice. For example, this patient, she's a 37-year-old married female, and she was started on statin by one of the doctors in primary care. And we will know that she actually was not a candidate to start statin, although the cholesterol is marked as high in her tests, but you will know at the end that, hopefully by the end of the lecture, you know why the statin was not indicated in her case. Similarly, this patient was told that his lipid profile is normal, and he does not need any medications to lower his cholesterol, because the values here written in the blood test are all within the normal reference range, that is the laboratory reference range. But this patient actually needed to be started on statin, and we also will know why at the end of the lecture. I encourage you all to go to the manual or the guideline for chronic diseases that was issued a few years ago and updated just yesterday. They updated the version, and for further details to go to the prevention and cardiovascular disease guidance. So my lecture will be based mainly on, let us say, the ESC EAS guidelines, which is the European guidelines, or the European Heart, European Society of Cardiology guidelines. In 2019, this was the last version that they issued a guideline to manage dyslipidemia alone. They're supposed to renew it this year, but till now it has not been renewed. But then in 2021, they issued another guideline for cardiovascular disease prevention in general. And in this guideline, they updated a lot of the risk assessment scores, and also the LDL targets. So we will mainly focus on the 2021 guidelines, because it is It is updated from the 2019. And also in 2023, they issued a guideline especially for patients with diabetes. And in this guideline, they also introduced a new risk assessment tool for patients with diabetes. So we'll also refer to this guideline specifically in my lecture. This is the outline of my talk today. I'll be speaking about the dyslipidemia definition and when to start screening patient risk categories and LDL goals, risk calculation, how to approach a patient with dyslipidemia in terms of history, physical exam, and lab tests, and how to treat dyslipidemia. I'll be talking very briefly about hypertriglyceridemia, and then I'll be presenting some cases from our practice. So what is dyslipidemia? Dyslipidemias are disorders of lipoprotein metabolism. They can result in any of the following abnormalities, either high total cholesterol, high LDL, low HDL, high triglycerides, or a combination of these, which we call mixed. Of course, you all know that dyslipidemia is a major risk factor for development of atherosclerotic cardiovascular disease. There is a linear there's a direct relation between plasma cholesterol and coronary risk ratio. And here in Kuwait, almost half of the deaths are due to cardiovascular disease. So it is the highest cause of death in Kuwait and also in the surrounding region. I'll just want to revise with you the classes of recommendations that are present in all guidelines. So when you see a class 1, then there's generally a very good evidence, and we know that this intervention is beneficial, and the intervention is recommended or even indicated. When we see class 2, class 2A, the intervention should be considered because the weight of the evidence is in favor of its usefulness. When we say class 2B, then it's may be considered because the usefulness is not established by strong evidence yet, but we can consider it, we cannot. And of course, whenever you see class 3, it is always in red. It means that this intervention is not recommended. There's also the level of evidence. Of course, level of evidence A, it means that it's derived from strong evidence like RCTs and meta-analysis. B, it's from randomized studies or clinical trials, and C, usually it's only based on consensus opinion, or very small studies. So these terminologies are important because when I will show you the recommendations for certain interventions, you should be informed about how confident or what's the evidence behind each intervention. Dyslipidemia are due to a primary cause, which is mostly familial or genetic. There are I will resume my lecture. Okay. Please remember that there are secondary causes for dyslipidemia, mainly hypothyroidism, diabetes, Cushing syndrome, nephrotic syndrome. That's why whenever a patient has abnormal TSH or thyroid function, you should treat the thyroid disorder first. Then you should look at the lipid panel if it's corrected with treating the hypothyroidism. Then or not, then you should go for treating his lipids or dyslipidemia. Also, of course, diet is a major cause. Some drugs also are known to elevate the lipids level, which are anabolic steroids, beta blockers, estrogens, including oral contraceptive pills and corticosteroids. So when should you start screening or do lipid testing as part of cardiovascular disease risk estimation? The majority of guidelines recommend to do that in men in 40 and above, and in women 50 and above. Of course, you should consider the testing earlier if your patients have known cardiovascular risk factors like hypertension, family history of premature cardiovascular disease, chronic kidney disease, diabetes, obesity, and smoking. And the reassessing lipids should be every 5 years, of course, if the results are normal, and unless the risk factors change. And you can use the non-fasting lipids to calculate the cardiovascular disease. So your patient do not need to be fasting in order to calculate his cardiovascular risk. So now, if we want to summarize the management of dyslipidemia, or the main principle of dyslipidemia, it should be done in 3 steps. The first step is you should determine the patient risk for developing atherosclerotic vascular disease. Then you should know what's the LDL goal or what's the LDL target for your patient, and then you should treat him to reach this LDL goal. Okay, so this is the main principle when you want to manage a patient with dyslipidemia. Now, in the 2021 guidelines, the patient categories, or they categorize the patients according to 5 groups. The first group is patients with established atherosclerotic cardiovascular disease. They've already had or established this atherosclerotic cardiovascular disease. Then the second category is patients with familial hypercholesterolemia. Always they refer to FH, the abbreviation. Patients with diabetes, especially type 2 diabetes, and patients with chronic kidney disease. Okay, so these are the 4 patients categories with disease that you need to exclude before or when you first encounter your patient. Is he having established atherosclerotic cardiovascular disease? Is he having familial hypercholesterolemia? Is he diabetic? Is he known to have chronic kidney disease? If not, if the patient doesn't belong to these 4 categories, then we call it apparently healthy. We call the patient apparently healthy. So these are the 5 categories of patients, and the corresponding risk factor for each. For anyone with established atherosclerotic vascular disease, then is a very high risk patient. Those with familial hypercholesterolemia, they're considered high risk, unless of course they have developed atherosclerotic cardiovascular disease, then they will be very high risk. Those with diabetes, we will learn how to categorize them according to the 2023 guidelines. They fall into 3 categories, either moderate, high, or very high. Those with chronic kidney disease, also they could be high or very high risk, and we will go through these subdivisions in the next slides. Now, if the patient is not belonging to any of these 4 categories, then we call it a patient apparently healthy. Here, you need to assess the risk for the patient using a risk assessment tool or a scoring tool. And this is where the score 2 and the score 2 OPD comes. We will also talk about them in the next slides. Here, your patient will fall according to his score, or to the score that you according to your risk assessment. He will fall either into low to moderate risk, or high risk, or very high risk. Okay. And usually the ultimate LDL goals, which is the best target for each category, if your patient has a very high risk, then it's the goal it's to be for the LDL is to be less than 1.4 when you treat the patient. If he's at high risk, then the goal is to be less than 1.8. And for these two categories, you need also 50% reduction of the baseline LDL. So if, for example, your patient starting at a number, for example, 4, then you need a 50% reduction. So you need it to be below 2 in addition to these two targets. If the patient is at moderate risk, then it's less than 2.6. And it was in 2019, they put this target for the low risk, but now in 2021, it is no longer mentioned because they have merged the low risk and moderate risk to one category. So they're no longer mentioning the less than 3. So the ideal is typically to be less than 2.6, and we're also going to go through these in the next slides. So whom are the patient with established atherosclerotic cardiovascular disease? As the name implies, either they have documented clinical atherosclerotic cardiovascular disease like previous MI or acute coronary syndrome, or they have stroke or TIA or aortic aneurysm, or they have in imaging, maybe they don't have a clinically, but in imaging they were found to have a plaque or coronary, or they did a coronary angio and they found a plaque. Then this we call it established atherosclerotic cardiovascular disease, and we said that this patient category is at very high risk. Patients with familial hypercholesterolemia are in general, all of them are categorized to high risk. Now, this has been updated in 2023 guidelines, especially for patients with type 2 diabetes. If your patient with type 2 diabetes has established atherosclerotic cardiovascular disease or has a severe target organ damage, which is specified by these points, that if he has an eGFR less than 45, or an eGFR between 45 and 59 plus microalbuminuria or proteinuria, or he has a presence of microvascular disease at 3 different sites, then this patient is automatically very high risk, and you don't need to calculate the score to diabetes risk for this patient. If the patient has no established atherosclerotic, yani he's type 2 diabetic, above 40, but he has no established atherosclerotic vascular disease or target organ damage, then you need to calculate his risk using a tool called SCORE2 diabetes. According to this risk calculator, if the percentage is 20% or above, then he's a very high risk. Between 10 and 20 is high risk, 5 and 10 is moderate risk, and less than 5 is low risk. Okay, so this is an update from the 2021 guideline that we're using a new tool called SCORE2 diabetes. How do you calculate the score? Please, if you don't have this app yet in your mobiles, I encourage you to download it now because it's free and it will save you a lot of time instead of looking at the charts. So from this tool or this app, you will choose this up to 10-year risk calculator, and then you will choose SCORE2 diabetes. And then you need all these parameters to enter in your calculator. For example, I chose here, first you will choose which country, or we will talk about these countries in a moment, but here you chose the gender, the age, and at what age the diabetes was diagnosed, what's the systolic blood pressure, what's the total cholesterol, what's the HDL cholesterol, HbA1c, and eGFR. I put all the results of one of my patients, and then the 10-year risk for cardiovascular event was 30.4%, which is of course very high risk. So I know now what's the category of my patient and what's the LDL target. Patients with chronic kidney disease, we said that they're either very high risk or high risk, and this is the specifications for severe. If they're severe chronic kidney disease, then they're very high risk, and if it's moderate, then they're considered to be a high risk. So you should know what's the definition for severe and moderate chronic kidney disease. Let's see some example for LDL, how to measure LDL LDL target. So this is a 59-year-old patient known to have hypertension. He's had a TIA, and his baseline LDL is 2.2. So we know that TIA means he's a very high risk. We said this is a clinical atherosclerotic cardiovascular disease. So the target LDL level will be, we said 1.4 plus 50% reduction of the LDL. That's why the target LDL will be 1.1, because we want 1.4 plus 50% reduction of the baseline. His baseline was 2.2. So in addition to the target that is well known like 1.4, we also need 50% reduction of the baseline. This patient has an eGFR of 35, and he's diabetic. So we also, and his LDL is 3. We said that any diabetic with an LDL less than 45 is automatically considered a very high risk. So his LDL target will be less than 1.4. And similarly, a patient with an eGFR of 55 and ACR of 40, he's considered high risk. So according to the chronic kidney disease, because he has moderate chronic kidney disease, then his LDL target will be 1.8. Of course, plus 50% reduction, which is already reached with 1.8. I know that many of you are familiar with this chart from the 2019 guideline. And it is a useful chart to memorize the LDL targets, but please be aware that they're using the score and not the score 2 or the score 2 OPD, the newer risk assessment and the newer risk assessment that they suggested in 2021. And some of these specifications for the risk groups have also changed a little bit. So maybe it will be useful to look for type 1 diabetes because they're not really well identified in the 2021. And some of the maybe criteria that stayed the same for each category, but the majority of these specifications have been changed. So just make sure that you follow the newer guidelines. For those who are apparently healthy, we said that we have to do the risk calculations for them. So we will use the score 2. Score 2 stands for systematic coronary risk estimation, and it measures the risk of both fatal and non-fatal cardiovascular events. This is the difference. The score in 2019 calculation tool measured only the percentage of cardiovascular deaths, so the fatal events. Here, this score measures both fatal and non-fatal, which is, of course, more applicable in our practice. So here they divided the patients into 3 categories according to their age. And for each age group, the percentage or the risk corresponds to either low to moderate, high risk, or very high risk. The percentage is not the same for all ages. You can realize that for younger ages, they're more strict, or the the numbers are lower than those and those who are elderly or higher age. So this is, when you look at the chart, you're going to see three color coding: green, yellow, and red. They're using these green for low to moderate, yellow or orange for high, and red for very high. And they're specifying each age group or each age category with the corresponding risk estimation. So the general rule is when your patient is low to moderate cardiovascular risk, then usually he doesn't need any treatment. It's generally you don't need any treatment. If he's high risk or very high, no. If it's very high risk, then the treatment is definitely recommended. In the high risk group, then you have the option to treat or not to treat. This is, of course, for the patients who are apparently healthy, not for patients who are the other categories. So here in 2021, they divided the countries according to their risks, or to some of the so you find some of the regions they're labeled as very high risk, and some of the labels are labeled regions or countries labeled as high risk, some moderate, some low. Unfortunately, Kuwait and the Gulf area is not included with this because obviously they didn't provide enough data to contribute to this risk assessment. But many of the Arab countries, you can see from Morocco, Algeria, Egypt, Syria, also all these countries are considered very high risk according to the data that they submitted. And we know that our data is almost similar to theirs. So we will consider our patients in the very high risk group unless this changes in the future. So this is the chart, the score chart. And I told you that it's much easier to use the app, to be honest, instead of like looking in the chart and seeing and calculating your patient's risk. But you can see that the chart has two halves. The upper half is for the older persons from 70 and above, and then the bottom half is for the younger age groups. And we said that now we have three categories, not four, similar like 2019. And there are four charts for according to the countries. So if the country is in low cardiovascular risk, it has a special chart. And the moderate cardiovascular risk countries have special charts. The high have special charts. And this is the very high cardiovascular risk, that the chart that mostly we will be using for our patients. And how are you going to use this chart if you don't have the mobile app? Then basically you have first to assess the gender of your patients, whether he's woman or men. And then, so if for example, we have a 45-year-old male, then we'll go to the right side of the chart, which is for males. And then if we want to know if he is a smoker or not, so he's not smoker, our patient. So we'll go to this side of the chart. And then you're going to calculate his non-HDL cholesterol, which is total cholesterol minus HDL. Okay, so you'll have to do the calculations. Here's 5.5 minus 1.6. So almost it's 1.1. Sorry, it's 4.3. So it lies in here. And if you're also going to see his blood pressure, which is 130/80. So almost his risk is calculated to be 5%. Okay, 5% means a high risk for a 45-year-old male. So you will know that the ultimate LDL goal for this patient is 1.8. If you use the risk assessment or the score, you will get a more more accurate result, to be honest. So here I put the same patient's data in score 2 in the app. Of course, I used very high risk because he's a Kuwaiti. And then when I put all the data, the result was 4.4, which is less than 5%, but still he's in the same category, which is the high risk category. So when we now, if we go through all these 5 risk categories of patients, you will see that there are some patients who you don't need to do score 2 because you know already their risk. First of all, patients who need secondary prevention, so they have established atherosclerotic cardiovascular disease, then they are automatically in the very high risk. You will not do score 2 for them, risk calculation. And also patients with primary prevention, diabetics, who have severe target organ damage, and we said which are the categories for severe target organ damage. They also at very high risk. Those with chronic kidney disease, they're high or very high. You don't need to do the score 2, and also those with familial hypercholesterolemia. Another thing that has been introduced in the 2021 guidelines is something called the stepwise treatment intensification approach, and also more customized approach to your patients according to their patient preferences and if they have comorbidities and the benefit of their risk. And this is it's recommended as a class 1B to do a stepwise treatment intensification. For example, this chart is for the apparently healthy persons, okay? Here, of course, always in step 1, you should do the lifestyle recommendations and lifestyle for your patients. And then you'll do a stepwise like treatments, because the risks, the categories are not automatically translated to directly, like, for example, if your patient is high risk, then automatically it will be 1.8. No, you can do a stepwise approach to reach this target, okay? And you should consider risk modifiers, lifetime cardiovascular risks, and patient preferences at each step of your patients. And also, on the other hand, they don't advise you to stop at step 1 routinely. So the step 2 is recommended to be taken in all patients, but sometimes you can stop at step 1 if the patient's circumstances allow to or needs to. So let me go to a more detailed explanation about this stepwise approach. Now, in a patient who's apparently healthy, we said step 1, you will do, first of all, lifestyle recommendations, including stopping smoking. For example, if your patient is less than 50 years and you did the 10-year cardiovascular risk score 2, and it was below 2.5, then the usual approach is, this is the line, which is clear line or in black. This is the usual approach. The dotted line is the alternative approach. So the usual approach, if a patient has a very low to moderate risk, that he needs no additional prevention goals. But if you should also, before you decide that he doesn't need any treatment, you should consider other risk modifiers. For example, if he is obese, if he has physically inactive, you have psychosocial problems. So maybe they have other things that favor or other risk modifiers that favor starting the treatment. So if he does have or مثلا patient preference or something called lifetime cardiovascular risk benefit, and this also you can calculate it with the through the app. They will refer you to another web page that you need to register, but it's a useful calculator tool, the lifetime CVD risk. It will show you the risk to develop cardiovascular disease not over 10 years but over lifetime. And for if you, and also you can remodify this lifetime risk if you add مثلا if I started statin, how much this risk will be less. So maybe your patient will be convinced if you know, like, for example, my lifetime risk is 30% to have cardiovascular disease, and if I started statin, it will be 20% reduced to 20%. He wants to take this step, so maybe you will choose to go to start treatment and to reduce the LDL to less than 2.6. On the other hand, if his patient is already in the high risk group, we said 2.5 to 7.5 for this patient is high risk, then the usual approach is that you will start treatment. This is the blue line. The usual approach is to start treatment and to reach to 2.6 on step 1, and then further intensification step 2 to reach to less than 1.8. This is the ultimate LDL goal. But if your patients, for example, doesn't prefer, or his risk modifiers are all in favor, that he's very fit patient, has no other risk factors, no family history, and he doesn't want to start treatment, then this dotted line, it's optional to not to add prevention goals or not to start him with statin. So this is called the you will consider each patient differently, and you will consider his preferences, and you do a customized or patient-centered approach. Of course, you can see if the patient is a very high risk, then he has this option is not available, which is that he shouldn't be receiving treatment. He should go to treatment directly because he's a very high risk. So only for those patients who are mild or moderate to high risk, you have this option to negotiate with the patient whether he needs or not. And then in step 2, if your patient also prefers, and he's not frail, and frail is defined as being like weak, or being with difficulty to move. They not necessarily they're elderly, but frail is the means that they're weak because usually they have comorbidities and polypharmacies, and they are susceptible to drug side effects. So maybe you will, and he does not prefer or to intensify his treatment further. So you might stop at step 1 and reach till less than 2.6 and stop there. If it's all these in favor of your patient, then you can intensify your treatment to reach the targets that we all already know, less than 1.8 for high risk and less than 1.4 for very high risk. The people who are in the middle age group are the same, they are similar to this chart. The difference is with those who are above 70 years, you can see that there's a class 2B evidence that we reach less than 2.6 for those who have high risk or very high risk. So you have the option to treat those who are very high risk, but only to reach 2.6 and not less. Of course, with those established atherosclerotic cardiovascular disease, you can see that all the recommendations are green. There's a very, very high evidence that all patients should reach as step 1 less than 1.8 and of course 50% reduction of baseline, and then less than 1.4 LDC, and you should go directly actually to this LDLC level unless there's like extremely frail patients or. And this is in 2024, they even advise a lower LDL goal, less than 1 of less than 1 if there is a recurrent antithrombotic event. And then next year, like if the patient has a recurrent MI or recurrent atherosclerotic event, and then you need to even lower the LDL more. But this is a class 2B recommendation, so there's not strong evidence to support that. But usually, cardiologists will go to this target. And for those with type 2 diabetes, according to the 2023 guidelines, if they're very high risk, then you need to reach less than 1.4. If they're high risk, then less than 1.8. And if they're moderate risk, then they should reach less than 2.6. These are the factors that might modify the scores, the score risks, and might influence your decision whether to start or not to start. Of course, to start if the patient has many of these factors, and if he has no other of these factors, maybe to defer the treatment. So physical inactivity, obesity, psychosocial stress, AF, chronic kidney disease, non-alcoholic fatty liver disease, obstructive sleep apnea, all these things. There's often a question about using other cardiovascular risk assessment tools. We know that there's a tool called Q-Risk. There's also Framingham. There's also the ASVD risk. Can we use these risks of calculators? Of course you can, but you should know that each of these risk tools has its own interpretation in terms of the calculated risk or the calculated number. So the numbers that you get from these risks do not apply to the numbers in the ESC guidelines. So you should, if you want to use these, then you should go to the interpretation that is specific to these calculators and not use the ones for the ESC guidelines. These are because you need to know if your patient has familiar hypercholesterolemia or not. Then you should also need when to suspect that a patient has familiar hypercholesterolemia. You can see that in this chart or this diagnostic criteria, they're using scores for each criteria. For example, if for LDLC, if it's from 4 to 4.1, this scores 1. Your patient here scores 1. And if, for example, he has tendon xanthomata, then he scores 6. And if they have a family history of premature cardiovascular disease, then he is also 1. So a patient with, like, for an example, an LDL of 4.5 and with tendon xanthomata and family history, then he's having 8 points, so he has almost a probable familial hypercholesterolemia. So whenever you suspect, you need to know these criteria, and whenever you're suspecting patients who has familial hypercholesterolemia, then it's better to be referred to a lipidologist or cardiologist, because they might have the opportunity to check for the genes or to do further testing to to know the patient's true risk and to start on appropriate treatment. Now let's see how we approach the patient with dyslipidemia. So basically in history, we said that we need to know the risk of our patients and to which category he belongs. And you also need to exclude secondary causes of dyslipidemia, and you also need to look for risk modifiers because they might influence your decision whether to start or not. So basically, so the first question you ask, does the patient have evidence of existing atherosclerotic cardiovascular disease, for example, coronary heart disease or stroke, or PAD, peripheral artery disease, or he did an imaging that showed that he has like obstruction of any of his arteries. So this is the first question. You want to know to find out whether he has diabetes or chronic kidney disease, and also you need to know to know his drug history, their drug intake, whether he's smoking, having alcohol, and then also you need to exclude other causes of dyslipidemia, such as hypothyroidism, liver disease, nephrotic syndrome. Does he have family history of hypercholesterolemia? For example, premature cardiovascular disease, or and they have premature death from cardiovascular disease. And what about the physical activity and diet? And does he have other like obstructive sleep apnea or chronic inflammatory disorder? And we also need to assess the psychosocial history, because we said that these are all considered risk modifiers and they might influence your decision to start treatment or not. When you do physical examination, you need to look for tendinous xanthomata, because we said that they're one of the criteria for familial hypercholesterolemia, and also arcus corneal and around the iris. You need also to measure the BP, BMI, waist circumference, and you need to check the fundus and neurological exam if he's diabetic, because you are looking for target organ damage. We said that any diabetic with target organ damage is considered a very high risk. And then the labs, of course, you need to have the full lipid profile measured at least twice. The gap between the two tests should be 1 to 12 weeks, except if your patient very high risk, then you don't need to repeat the lipid profile. You also need to do the HbA1c, liver function, TSH, renal function, and eGFR, and if creatine kinase, if he has unexplained muscle pain. These are the basic labs that you need to order for your patients. Now, how do we manage? Of course, the first line of therapy for all the risk groups is therapeutic lifestyle changes. Okay, it starts with a healthy diet. The recommended is the Mediterranean diet, or something similar, which is low in salt and saturated fat, focus on whole grain products, vegetables, fruits, and fish, and they should avoid refined carb and processed meats and food rich in trans fats. The physical activity should be a mix of aerobic and resistance exercises. So aerobic exercises, either 150 to 300 minutes per week of moderate intensity, or 75 to 150 minutes per week of vigorous intensity. And your patient should encourage to do resistance exercises 2 or more times per week. So you need a mix of these two. Of course, he needs to reduce his weight, to have an ideal BMI and an ideal waist circumference, stop smoking, and stop alcohol. These are the main therapeutic lifestyle changes that should be always taken by your patients. Now, for the pharmacological therapy, of course, the treatment with class 1A, like a well-known treatment that has been studied well and have the strongest evidence is statin. So it's always recommended to start a statin at the highest tolerated dose to reach the LDL goal. If the statin is not if the LDL goal is not reached with statin alone or with the maximum amount of statin, then you should combine it with ezetimibe. It's also grade 1, but the level is B, not A. Now, for the PCSK9 inhibitors, the injectable medications for treatment of hypercholesterolemia, you can see that the strongest evidence to support their use is for people who already have established atherosclerotic cardiovascular disease. So we call it for secondary prevention, okay? For secondary prevention, and if they didn't reach their LDL goal with statin and ezetimibe, then you will add the PCSK9 inhibitor. Okay, for primary prevention, the evidence is still very weak, 2BC, okay? But you may consider them if your patient is only at very high risk for primary prevention, but very high risk. And of course, if your patient didn't reach the LDL target with ezetimibe and statin, then you may add the PCSK9. Another indication for PCSK9 for primary prevention is for patients with familial hypercholesterolemia who are at a very high risk. Okay, then also you can start here PCSK9, of course, after statin and ezetimibe. Okay, so this chart shows you the pathway that if your patient is indicated for drug treatment, and you should start first with high potency statin. High potency means effective statin, which are the statins that are available in our clinic. Okay, to reach the LDL goal. If the LDL goal is not reached, then you will add ezetimibe. If it's not reached, then you can add PCSK9 inhibitor, especially if you have for secondary prevention or for familial hypercholesterolemia for primary prevention. And here, this chart shows you that a moderate intensity statin can lower the LDL approximately 30%. High intensity will lower it approximately 50%. High intensity plus ezetimibe 65%. PCSK9 inhibitors alone can lower the LDL by 60%. And if they're added to high intensity statin, they can lower it by 75%. Of course, if they're added to statin and ezetimibe, you'll reach the maximum LDL reduction of 85%. What is the divisions, or what doses are considered high intensity and moderate intensity and low intensity for statin? For the brand Lipitor, high intensity is 40 and 80. For brand Crestor, 20 and 40. So with this intensity, you will reach approximately 50 or more LDL reduction. Those with moderate intensity will reach 30 to 49% LDL reduction, which we have the Zocor 20 and 40, Lipitor 10 and 20, and Crestor 5 and 10. Low intensity are not available in our clinic. So all the concentrations that we have are either moderate or high.
دكتورة ياسمين، السموح على المقاطعة بس 10 minutes. 10 دقائق.
Sure. Okay. So the contraindication to start prescription is people with active liver disease, or if they have more than 3 upper normal elevated transaminases, and also people, women who are pregnant or breastfeeding, or women who are of childbearing age not using appropriate contraception. And the commonest side effects is that they cause musculoskeletal and connective tissue pain sometimes, and they cause GI side effects. They also might cause hyperglycemia, and they can cause an increase in serum transaminases. These are common used drugs that may increase the risk if they are combined with statin. They might increase the risk of rhabdomyolysis. And this is the statin dose adjustment that you need to take when your patient is in chronic kidney disease. You can see that the only drug that you need to adjust the dose is rosuvastatin, which is Crestor. Regarding atorvastatin and simvastatin, no need for dose adjustment. And then after initiating statin, you should repeat the lipid profile panel 4 to 12 weeks, yani 1 to 3 months. If the LDL goal is reached, then annually. The liver function test once, you must repeat it after 8 to 12 weeks. And then if it's normal, then you don't have to repeat it. If the your patient have unexplained muscle symptoms, you might order for CK. And you also need to check the HbA1c after 3 months, because especially for those people who are at high risk of diabetes mellitus, because we said that statin can induce hyperglycemia. So if we have a patient who is on Lipitor 40, he's for primary prevention, and he complains of not tolerating the medicine because of myalgia. His CK, you measured his CK, it's normal. So now what's the best management option? Should I stop it temporarily and start again at the same dose? Or shall I reduce the dose to 20? Shall I change it to Crestor? Shall I try alternate day dosing? Shall I change it to ezetimibe or fibrate or PCK? PCKS9, sorry, here I missed the S. So actually there are more than one correct answer here. I just wanted to show you this graph that out of 100 patients on statin, 15% report muscle symptoms, but only one will be due to statin. The others will be muscle symptoms because of other issues. So you always have to investigate what is the cause of the true cause of myalgia for your patient. And then this approach is correct. You can stop it temporarily and then start again at the same dose, because here again we're doing primary prevention. If the patient is for secondary prevention or very high risk, then this option is not valid. You can reduce the dose to 20, although Lipitor company, they claim that their side effects are not dose dependent for their treatment or for their brand. You can change it to another statin with similar equivalency or similar potency. And also you can try the alternate day dosing, but no need to change to ezetimibe or fibrate, or of course it's very prematurely to change also to PCSK9. I will skip these 2 slides. Ezetimibe is also another option, which is also available in our primary cancer centers, ezetrol. You can, of course, add it to cholesterol, to statin, if your patient is not reaching the goal. It increases the risk of transaminase and myopathy, so be careful. Also monitor that in your patient. And the PCKS9 inhibitors, they will soon be available in primary care, and you will be able to prescribe them for your patients. So they are subcutaneous injections, injected every 2 weeks. And we said that the main indications is for secondary prevention if if the LDL is not reached with statin and ezetimibe. For primary prevention, for those with patients with familial hypercholesterolemia, you can also prescribe them in addition to statin and ezetimibe. And if your patient doesn't have familial hypercholesterolemia, but he's at very high risk, you may also prescribe it. Other than that, there's not strong evidence to support their use. They're also generally well tolerated. They might cause, the most common side effects they cause is flu-like symptoms, headache, nasopharyngitis after the few days after the injection. They might also cause myalgia. This is also one of the newer medication, which is injection, biannual injection. It's available in the hospitals, but not yet listed in the guidelines because the evidence is still undergoing for their use. Okay. Now there's one aspect is when using non-HDL as a secondary target of therapy. We said that the main target for our treatment is the LDL. Sometimes we also want to the non-HDL to be also lower, and especially if the patient has diabetes, high triglycerides, or his patient's obese or with very low LDL, because usually these patients, the LDL cholesterol is not very well accurate. So here you use the non-HDL. You simply subtract total cholesterol minus LHDL, and usually the non-HDL target is 0.8 millimole higher than the LDL target. So for very high LDL risk patients, the LDL goal is less than 1.4, and the non-HDL is 2.2, which is 0.8 millimole higher. And similarly for patients with high and low to moderate risks. Why do we need sometimes to calculate the non-HDL? Because the non-HDL gives us a better indication for the atherogenic ApoB containing lipoproteins. All these lipoproteins have atherogenic particles. So when you subtract the total cholesterol minus HDL, you will have all these particles. You can have a more accurate estimate of the atherogenic particles in your patients. The last topic is hypertriglyceridemia. There are 3 slides only, and then I don't know if you will give me time to discuss few cases. If not, then maybe I'll just distribute the slides for everybody later for them to study them alone. So for the hypertriglyceridemia, we know that high triglycerides usually are caused by these either medications or by diabetes, especially if the sugar is uncontrolled, metabolic syndrome, obesity, poor diet, of course, sometimes genetics, and also alcohol use. This is the new categorization of hypertriglyceridemia from up to date 2025. So the normal level should be less than 1.7. Between 1.7 and 5.6, this is called moderate hypertriglyceridemia. From 5.6 to 11, this is moderate to severe. And above 11.3 is severe. Okay. The ESC guidelines tells you that you should always start treating hypertriglyceridemia with statin. So this is class 1A, okay? And then so first of all, treat with statin till you reach the LDL goal. If you reach your LDL goal and the triglycerides are still above 0.23, then you might add fenofibrate. This is what class 2B recommendation, so there's not a very strong evidence supporting their use. And also in very high risk, if your triglyceride is above 0.5 despite statin treatment, then you might add special types of omega-3, which is the icosapent ethyl. 4 grams you can be considered with the statin. What do up-to-date tells? In up-to-dates, maybe the recommendation is also very similar, but I've summarized it in this diagram. Now, if your patient has moderate hypertriglyceridemia from 1.7 to 5.6, of course, the first step is to adjust their lifestyle, okay? Treat the secondary causes and adjust their lifestyle. And then you should treat them with maximum statin therapy, plus ezetimibe, plus PCSK9, if it's indicated, to reach the HDL goal and the non-HDL goal before thinking about treating the triglyceridemia. So if you reach the LDL and non-HDL goal with these treatments and still the triglycerides is above 1.7 and your patient is in high risk and very high risk, then you can prescribe the omega-3 kind, a special kind of we call it, it is called icosapent ethyl, which is EPA containing EPA containing omega-3 omega-3 supplements. And actually this you will not find it in the traditional over-the-counter omega-3 supplements. This is a prescription medication, the Vascepa. It's a prescription medication because it only contains EPA without DHA. Usually all the over-the-counter supplements, they contain both EPA and DHA, but here they're recommending EPA only supplements in a very high dose for those very high-risk patients only. Okay, I found something similar in iHerb, which is EPA only. This is 500, so you need to take, if you want to reach 4 grams a day, you need to take 8 tablets. This is a very high dose. Now, if your patient has moderate to severe from 5.6 to 11, then again, of course, you should treat with maximum statin therapy and you should reach the LDL and HDL goal. If your patient here is the target is not reached, the LDL target is reached and the triglycerides is still above 2.3, you might add fibrate, which is Lipenthal. And if it's the TG remains above 5.6, you might add, after adding fibrate, you might add the regular omega-3, which is maybe well-known. An example of it is Omacor. If the patient high risk or very high risk, they advise to take the EPA only, this one, the high dose icosapent ethyl. Okay, so in patient without high risk, Lipenthal and regular omega-3. In patient very high risk, they advise to take the EPA only containing omega-3s, which is a very high dose. And of course, if it's severe, then please refer your patients because these are at very high risk to develop pancreatitis. Here, there is no role of giving any omega-3 in patient. He needs a strict dietary, restrict dietary fat to almost very, very low levels. And you might start fibrates and refer. Okay, of course, if he needs also a statin therapy, as indicated, then they might start on. Now, I still have the cases from practice. I'm not sure if
Doctor, it's okay. We have 5 minutes
okay.
extra, for example.
So let's see this patient. He's a 51-year-old male. He's known to have diabetes. He's taking Lipitor 20, okay? And you can see that his triglycerides is high, 3.8, okay? And his LDL is 2. هذا هني مو واضح صراحة. His LDL is 2 and non-HDL is 3.5. If you want to, according to his risk, the LDL goal should be 1.8 because he is a high-risk patient. And accordingly, also his non-HDL, if you added 2.8 to 1.8, then it's 2.6. So he still, we need to intensify his treatment in order to reach the LDL target and the non-HDL goal, and then we will see whether we need to consider adding triglycerides for this patient, adding the treatment for his triglyceridemia. So intensify his treatment till he reaches the LDL and non-HDL goal, and then you might consider, of course, he's in a moderate hypertriglyceridemia, so most likely he needs nothing beyond that. He will not need, unless he's, of course, a very yeah, he's a high risk, so he might be considered for EPA, which is EPA omega-3. Similarly, this patient, he's a 59-year-old diabetic, and he has a peripheral arterial disease as well. He's newly diagnosed diabetes, and look at his lipid panel. So he has total cholesterol is 6.8. His triglyceride is 6.45. They couldn't measure the LDL. Usually, if the triglyceride is above 4.5, the LDL cannot be calculated. So the non-HDL cholesterol is 5.7. Of course, he's a very high-risk patient, and the LDL needs to be less than 1.4, and the non-HDL needs to be less than 2.6. So, sorry, less than 1.8. So, in this case, the first, of course, before anything, you must control the blood sugar and treat his blood sugar. Then you must start statin plus ezetimibe plus PCSK9 to reach the non-HDL goal target. If triglycerides remains high, then you might here start fibrate, and then after fibrate, if triglycerides remains high, you might start EPA because he's in the moderate to severe hypertriglyceridemia. Okay. Now going back to this lady who was 37-year-old female, and one of the doctors started her already on statin. Why do you think she doesn't need statin treatment? Of course, because she is in childbearing age, and if she does not have contraception, proper contraception, then it is contraindicated to start on statin. Any patient below 40, actually, it's difficult to estimate the risk for this patient if he's apparently healthy, and she's not yet qualified for statin treatment. Of course, we can advise her for lifestyle intervention, but lifestyle treatment, statin is not indicated. And of course, maybe now you know why this patient who was told that his cholesterol is okay, it is not actually okay, and he should be on statin. When we calculated his score 2, he's diabetic, and when we called it his score 2 diabetes, it was 20%, which is very high. His LDL target should be less than 1.4. So his LDL now is 2.1. He needs statin to reach this further control of his LDL. Let us see how you'll assess this patient. She's a 60-year-old female. She has familiar hypercholesterolemia.
Excuse me,
خلص
you don't mind, this is last exam.
Oh, okay.
Because we have 2 questions.
مو مشكلة.
Thank you.
So she's familiar hypercholesterolemia. She's already on Lipitor and ezetimibe, and her LDL is 3. So what's the option? The best is to add PCSK9 inhibitor, because usually she's on a high dose and Lipitor. So changing from 40 to 80 will not reach the target LDL, which is we want more than 50% reduction of her baseline. So usually PCSK9 inhibitor here is indicated. الباقي أتوقع ما عندنا وقت. بس بروح على السريع ما يخالف. So this is a patient who's 65-year-old, newly diagnosed type 2. ACR is 50. He needs to be started on high dose statin because he's a very high risk. Okay, although his LDL is 2 and triglyceride is high, but he needs a statin because his LDL target should be less than 1.4. And yeah, he's in this category, in the severe target organ damage, type 2 diabetes with severe target organ damage. And this is apparently healthy, old person with 31.8 score OP. The best is to start with a moderate intensity statin to reach the target goal of 2.6. وآخر واحدة لأن هني قلنا he needs to be 2.6. فhis baseline LDL is 4.2. آخر واحدة بقت آخر case. For this lady LDL مالها 4, so she's apparently healthy she's in the low risk, so lifestyle treatment alone is enough for this lady, since هي and the less her risk category is less than 5%. Okay, this diagram concludes for 5 categories, and if you need which risk calculator you need, what are the risk categories, and what's your step 1 LDL goal and step 2 ultimate LDL goal for the patient. Thank you. I'm sorry for keeping you.
Thank you, Dr. Yasmeen, for an amazing lecture. There is a lot of questions, but because of the time, we can take one question if you don't mind.
Yes, definitely.
Question: how do you assess cardiovascular disease risk in patients under 40 years old? Do you use any specific risk calculator for these younger patients, such as AHA?
Actually, there are no existing calculators for those below 40, but you can use the lifetime cardiovascular risk, which is also if you from the app اللي هو ESC app application تختار lifetime cardiovascular disease. هذا this calculates the risk for younger people who are less than 40 years. And of course, if you're suspecting that your patient is having familial hypercholesterolemia at a young age, then also he should be referred. ممكن نسوي له further testing and genetic testing. Then they might also يعني الليبيدولوجيست ممكن يساعدك إنه to determine his whether he is a candidate to start statin ولا لا. But usually those below 40, you don't have a good, you won't be able to have a definitive estimation for their cardiovascular disease risk.